Welcome to this last video on Intro to Screeners. Now, understanding diagnostic tests in psychology is a process, and it's a process of diagnosing mental disorders that necessitates a multifaceted approach, where you as future clinicians will utilize standardized instruments such as self-report questionnaires, structured clinical interviews, observations, and many more. Now, assessments can produce both binary and continuous outcomes, each with their unique challenges and benefits. Today, we're going to go into ROC curves. But before I do that, let's talk a little bit more about these diagnostic tools and their range. Different psychological disorders require different types of assessments, and the nature of these tools vary widely. Tools like the Beck Depression Inventory may range from 0 to 63, with the divisions to define mild, moderate, or severe depression. The Generalized Anxiety Disorder 7-item scale, or the GAD-7, is another example with scores that can be used to measure the severity of generalized anxiety disorder. The MMPI can help in identifying various personality structures and psychopathology. We also have binary diagnostic outcomes, and they're clear cut, usually yielding a yes or no result. And they can be efficient in some contexts, but may oversimplify complex psychological phenomena. Now, some screening tools like the Columbia Suicide Severity Rating Scale might determine an immediate risk of self-harm or suicidality, demanding immediate action. But there is a threshold for clinical attention. Some assessments might provide a binary outcome, indicating whether an individual crosses a threshold needing clinical intervention, but there are some limitations because although straightforward, binary outcomes might miss nuanced information about the severity, subtype, or comorbidities of a disorder. Continuous outcomes provide more detailed information, and it gives a numerical score that needs interpretation. These are common in psychology and offer a richer understanding of a patient's condition, but introduce complexity in defining precise cutoff scores. Scores like those on the BDI must be interpreted based on a threshold, which can change depending on the population or context. Some tools allow for a more nuanced analysis of the severity of symptoms. A continuous outcome can help clinicians tailor treatment to the individual's specific needs. We also have comorbidity considerations because a continuous assessment can help in recognizing coexisting disorders and the interplay between different symptoms. But determining the right cutoff score is crucial for accurate diagnosis, yet challenging. A low threshold might overdiagnose, while a high one might miss genuine cases. Professional guidelines, expert consultation, and statistical techniques like the ROC curve are often used to determine these cutoff points. The ROC, which is known as the Receiver Operating Characteristic Analysis, is a statistical method used to evaluate the performance of diagnostic tests or classifiers. It serves as a vital tool in the psychological assessment process, specifically for analyzing and selecting the threshold for various diagnostic tests. It can be applied to various mental health conditions and offers an insightful view of the performance of the validity of a test. ROC graphs are like a report card for a machine that's trying to sort things into two categories, such as sick versus healthy. They show how well the machine is doing at its job. So imagine, again, separately, you have a machine that's trying to detect whether an apple is ripe or not. An ROC graph helps you understand how often the machine is right, meaning does it call a ripe apple ripe, and how often is it wrong? It calls an unripe apple ripe. Psychologists use these graphs to see how well a diagnostic test is working. People have been using ROC graphs for a long time in different fields, like medicine and computer science. But recently, they become even more popular because they're good at showing how well something works, even when the task is really tricky. It determines different cutoff scores that will be analyzed. It also lists sensitivities and specificities because it analyzes the true positives and the true negatives at each threshold. You graph the sensitivity against 1 minus the specificity for each threshold, and that's what creates the curve. Then you analyze the curve by interpreting the shape and position of the curve to understand the test performance. So how do these graphs work? Well, let's start off with classifier performance. A classifier is like a sorting machine. Sometimes it sorts things into two simple groups like yes or no. Other times it gives it a score that helps decide which group something belongs to. Now, the space of an ROC graph. An ROC graph is a picture with two parts. We have the TP rate, which is the true positive rate, and it goes up the side and shows how often the machine is right. We have the false positive rate, and that goes along the bottom and shows how often the machine is wrong. In a perfect world, we'd want a machine that always is right and is never wrong, but that's not always possible. If the machine only says yes or no, it makes a single point on the graph, but it gives scores. You can make a curve that shows how it does at different levels. You create an ROC curve by looking at the machine's score scores for different things and plotting how well it does at each point. The curve helps you see how the machine does without worrying about how many ripe or unripe apples there are. You can see how it does in general. We also have the concept of the area under the curve. You can measure how good the curve is by looking at the area underneath it. A perfect curve would fill the whole space, while a terrible one would just be a straight line. But notice the orange line here on the left side, that would be a really bad curve. Here's that perfect curve I was talking about on the left, but I also want to talk about the line of no discrimination on an ROC curve. It's the 45-degree diagonal line from the bottom left corner to the top right. If the ROC curve lies along this line, it means that the test does not have the ability to distinguish between the true positives and false positives. Essentially, this equates to random guessing, like flipping a coin, and provides no valuable information for decision making. In practical terms, a test that falls on this line would be deemed useless for clinical or diagnostic purposes. In contrast to the line of no discrimination, a perfect test would be represented by an ROC curve that reaches the top left corner of the graph. This means that sensitivity, and as you remember, it's the ability to correctly identify true positives, is 100%, and the false positive rate is 0%. In real world terms, this test would perfectly classify all individuals with and without the condition without any error. Such an ideal scenario is rare in practice, but serves as a theoretical goal for diagnostic test development. The area under the curve is a valuable summary statistic of the ROC curve. It encapsulates the overall ability of the test to discriminate between those with and without the condition. An AUC of 0.5 corresponds to the line of no discrimination, indicating no diagnostic value. As the AUC approaches 1.0, the test performance improves. An AUC of 1.0 would correspond to the perfect test. In general, a higher AUC suggests a more effective test, and is often used to compare the performance of different diagnostic tools. The impact of the curve's shape provides nuanced insights into how the test performs across different thresholds. A steeper curve in a particular region may indicate that the test is especially effective in distinguishing positives and negatives at specific threshold ranges. This could guide clinicians in selecting the most appropriate cutoff values for their particular context, balancing the need to detect genuine cases against the risk of false positives. Understanding the shape of the ROC curve helps in tailoring the use of the test for different populations and settings, enhancing its practical utility. Let's look at the line of no discrimination in an example. Let's look at it for a poorly designed anxiety scale. Imagine a self-report anxiety scale that was not properly validated. If it produces an ROC curve along the line of no discrimination, clinicians would know that it's ineffective in differentiating between those with and without anxiety disorders. It would be equivalent to randomly guessing who has anxiety, making the tool unfit for clinical use. An example of a hypothetical for perfect depression screening would be like, while ideal tests rarely exist, a perfect ROC curve in depression screening would mean that the tool could flawlessly identify every individual with depression without mistakenly categorizing non-depressed individuals. This theoretical example sets a standard for what the diagnostic test should strive for. For the area under the curve, let's compare PTSD assessments. Suppose two assessments are used to diagnose post-traumatic stress disorder. One has an AUC of 0.80 and the other has an AUC of 0.92. Clinicians could use this information to choose the latter, as it likely provides a more accurate diagnosis. And let's look at the impact of the curve shape on, for instance, an eating disorder screening tool. The shape of the ROC curve for an eating disorder screening may reveal that the tool is highly effective in a specific range of severity, but less effective in others. This information can guide clinicians in choosing appropriate cutoff points based on the population they're serving. Let's look at an example of a bipolar disorder screening tool. Let's say we had a threshold of 0.02. This would be highly sensitive, but may identify too many false positives, meaning those with unipolar depression or other mood disorders as having bipolar disorder. If we had a threshold of 0.95, this would be highly specific, but it's going to miss many genuine cases of bipolar disorder, potentially leaving them untreated. If we had a threshold of 0.34, this would be a more balanced approach that attempts to minimize both false negatives and false positives, but may still result in some misclassifications. These are not hard cutoffs. These are just general interpretations. Through these examples, I just want to show how ROC curve analysis in clinical psychology can guide the selection and interpretation of diagnostic tools, which would allow for more nuanced and effective patient care. The process of selecting an appropriate threshold for psychological assessments is multifaceted. This decision is fundamental for the accurate diagnosis and subsequent treatment planning for various mental health conditions. It must be grounded in both statistical analysis and clinical judgment, encompassing considerations like sensitivity, specificity, and the unique needs of different different clinical contexts. To balance sensitivity and specificity, we'll use something called the Uden index. This statistical method helps to find a point where both sensitivity, your true positives, and specificity, your true negatives, are balanced. It may be particularly relevant for general screenings where equal emphasis on false positives and negatives is essential. The Uden index, denoted as J, is a single statistic that captures both sensitivity and specificity of a diagnostic test. It's defined as J equals sensitivity plus specificity plus 1. And here's the interpretation. The Uden index ranges from 0 to 1, 0 indicating no diagnostic ability, meaning neither sensitivity nor specificity is better than random guessing, whereas a Uden index of 1 represents a perfect case with 100% sensitivity and 100% specificity. So to repeat, 0, no diagnostic ability, 1, perfect test with 100% sensitivity and 100% specificity. A higher value of J indicates better performance of the diagnostic test, as it considers both true positive and true negative rates. The Uden index is often used to select the optimal cutoff point for a diagnostic test. By plotting J for different threshold values, one can identify the threshold that provides the best balance between sensitivity and specificity. The Uden index can also be used to compare different diagnostic tests or classifiers. By comparing the J values, it can help identify which test performs better overall. But there are limitations. The Uden index assigns equal weight to sensitivity and specificity, so it may not be suitable if one of these metrics is more important than the other in a particular context. The index is typically applied to binary classification problems, so it might be more limited in cases with more than 2 outcome categories. In a psychological assessment setting, the Uden index can be utilized to determine the optimal threshold for categorizing individuals as at risk or not at risk for a specific mental health disorder by considering both these false positives and true positives. In highly sensitive scenarios where missing a diagnosis could have severe consequences like suicidal ideation, clinicians must prioritize sensitivity, even at the cost of some false positives. In highly specific scenarios, in settings where overdiagnosis might lead to unnecessary treatments or stigma, like an ADHD diagnosis, so specificity might be emphasized here. There's also ethical considerations. The chosen threshold must align with ethical principles, considering both the welfare of the patient and broader societal impacts. Let's look at an example for assessment in anxiety disorders. So depending on the presenting symptoms and clinical context, different thresholds might be set to distinguish between disorders like generalized anxiety disorder, panic disorder, social anxiety, and more. Or if you're screening for eating disorders, utilizing the ROC curve to determine optimal cutoff points can enhance the accuracy in identifying different types and severities of eating disorders. Or a childhood ADHD diagnosis, the careful selection of a threshold for tools like the Conners' rating scales ensures accurate diagnosis, contributing to effective treatment planning and minimizing misdiagnosis. Across different populations and settings, we have to think about cultural sensitivity. The threshold might need to be adapted to different cultural contexts to ensure that it's relevant and non-discriminatory. Different age groups, especially children versus adults, might require different thresholds to accurately reflect developmental variations. And in specialized populations with specific needs or characteristics, like veterans or trauma survivors, the threshold might need to be tailored to reflect their unique experiences and symptoms. When it comes to positive predictive values, the ROC curve stands out. Remember that the PPV represents the proportion of true positives among all positive screens. By studying the ROC curve, we can select a threshold that maximizes this value, ensuring that a positive screen is more indicative of a true positive. A negative predictive value allows us to find a balance where negative screens are most likely to represent true negatives. By analyzing the ROC curve for this aspect, we safeguard against missing genuine cases of mental health conditions, which might need immediate attention and treatment. In understanding diagnostic tests, 2 key terms come to the forefront: sensitivity, which tells us the percentage of actual positives that the screener correctly identifies. High sensitivity, as seen on the ROC curve's y-axis, ensures that we're catching as many true positive cases as possible. And this is vital for early detection of serious mental health conditions. Specificity, on the other hand, helps us gauge how well a test identifies the true negatives. By focusing on this aspect of the ROC curve, we can minimize overdiagnosis and save valuable resources and prevent undue stress. Some more diagnostics in the ROC. It helps us navigate the complexities of false rates and prevalence. So for false negative and positive rates, understanding these rates through an ROC curve enables us to weigh the risk and benefits of different thresholds, considering both the needs of the individual patient and the broader healthcare system. For the selection ratio and base rate, you consider these factors as a clinician to select appropriate thresholds for specific populations, considering the prevalence and specific characteristics of mental health disorders within the community. The low base rate phenomenon, this raises significant challenges, especially for rare conditions. The ROC curve aids us in navigating these challenges, ensuring that we don't let false positives overshadow true positives. Lastly, the ROC curve guides us in the optimal cutoff selection by balancing sensitivity and specificity. It helps us align our diagnostic approaches with local realities and needs. Also, adhering to standardized diagnostic criteria such as the DSM, this is vital for the ROC curve's effectiveness. Some things to watch out for. When you average your ROC curves, this means when multiple diagnostic tests or algorithms are compared, you might be tempted to average their ROC curves to get a single representative curve. This might be done to evaluate the general performance across different models or settings. Why it's complex? Well, averaging ROC curves isn't straightforward, as the curves represent different thresholds, sensitivities, and specificities. Simply looking at the curves or averaging them might miss underlying nuances, and care must be taken to use appropriate statistical methods and to understand the context in which the models are applied. What does more than two classes mean? Well, ROC curves are often used for binary classification, but sometimes they might need to classify into more than two categories, like mild, moderate, and severe. Multi-class classification introduces complexities, as you have to consider how each class is distinguished from the others. It might require pairwise comparisons between classes or the application of techniques like one versus all, leading to multiple ROC curves. Interpretation becomes more nuanced, and then careful consideration would be needed on your end to apply these tools effectively. When you're mixing different classifiers, this means that a single diagnostic tool or algorithm may not provide the desired results, and there might be a need to combine different classifiers, and this could mean merging different models or tools to take advantage of the respective strengths. It's complex because combining classifiers requires a deep understanding of how each one functions and where they might complement or conflict with one another. There are different methods for mixing classifiers, each with its own benefits and drawbacks. Careful calibration and validation are needed to ensure that the mixed classifier performs effectively and doesn't introduce unexpected biases or errors, combining information from various tools to provide a comprehensive diagnosis. Its application in the field demands consideration of both ethical and methodological aspects. The ROC curve allows for rigorous, evidence-based approach to decision-making, as it visualizes the trade-off between sensitivity and specificity at various thresholds, providing a quantitative basis for choosing the optimal cutoff point. While the ROC curve offers valuable insights, it should not be used in isolation. Clinicians must integrate the information derived from the ROC curve with their understanding of the patient's unique context, needs, and values. Balancing statistical data with human insights ensures a more holistic approach to care. You also want to avoid bias, like sensitive disorders. What I mean by this is particularly when dealing with stigmatized or sensitive disorders, biases and threshold selection can have significant consequences. These biases may stem from cultural norms, personal beliefs, or systemic pressures. The ethical application, well, it's incumbent upon mental health professionals to approach the selection of thresholds with transparency, neutrality, and an awareness of potential biases. Only by consciously recognizing and mitigating these biases can the ROC curve be ethically applied. You also need statistical expertise. Generating and interpreting an ROC curve involves complex statistical methods. The process demands precision and a deep understanding of the underlying statistical principles. Collaboration with statisticians or professionals trained in the statistical analysis may be necessary to ensure accuracy. Inaccurate application or interpretation of the ROC curve can lead to misdiagnosis or suboptimal treatment planning. So to conclude, the ROC curve is more than a mere statistical graph. It's a pivotal instrument in the psychological diagnostic process. Its applications extend across various psychological disorders, and it has the potential to enhance the accuracy and effectiveness of assessments significantly. However, the utility of the ROC curve must always be paired with clinical acumen, ethical consideration, and an awareness of the broader socio-cultural context. By aligning statistical analysis with human empathy and ethical principles, clinicians can leverage the ROC curve to make more compassionate, informed, and effective decisions in mental health practice. Here is a summary slide in which you can pause now and read over. But that's going to be end of this series of Validity and Intro to Screeners.